Yeah.
Should I start, sir?
Yeah, please.
Yeah, so today we shall be discussing about status epilepticus. So we all know the definition. Previously, it was told that it was more than 30 minutes, and all that is not used anymore. We have a conceptual definition which is given by Eiley in 2015. So this is almost same with the operational definition, which says we have two parameters here, T1 and T2. T1 is the time beyond which you label that as status epilepticus. That is because you have continuous seizure activity. And T2 is the time beyond which you label that as you have a chance of permanent neurological sequelae. So that is the concept of T1 and T2. T1 is the defining time for status, and T2 is the point beyond which there is an expected neurological sequelae. So this, when not mentioned specifically, so it's taken as 5 minutes because GTCS, that is generalized tonic-clonic status epilepticus, is the most common one. So if not mentioned, so we take T1 as 5, but we specifically look into the semiology of seizure. For tonic-clonic seizures, the T1 is 5 minutes. So beyond 5 minutes, we say that it is tonic-clonic status epilepticus, and beyond 30 minutes, we expect a neurological sequelae that for the tonic-clonic seizures. For focal seizures, without consciousness, that is with loss of consciousness, without loss of consciousness, that is 10 minutes. And T2 is beyond, that is 60 minutes. That is neurological sequelae after 60 minutes. Pardon? And for absence seizures, it is 10 to 15 minutes as a T1, and T2 is not known because absence seizures usually tend to happen over time or a long duration of time. So this is the concept of T1 and T2. T1 is basically to define the cutoff for status epilepticus, and T2 is beyond which there is a permanent neurological sequelae. So we'll look into the epidemiology per se. The estimated incidence is around 17 to 23. This is Western data per 1 lakh population. And amongst all the causes of amongst all the causes of status epilepticus, febrile status epilepticus is the most common one. And the incidence is almost the highest in the first year of life, that is in infancy. So it could be, we'll look into the etiology in the next slide. So before we'll looking into the etiology, we'll have to classify the status epilepticus based on the semiology. So whether it is focal or general or absence or some other type. So as we define or classify seizures per se, in the status epilepticus also, we divide focal status without impairment of consciousness, that is previously called as simple partial status, or it could be focal status epilepticus with impaired consciousness, that is complex partial seizures. So this is focal, and you can also have generalized tonic-clonic convulsive seizures and also absence type. So generalized is the most common per se. So that is the classification of status based on the semiology. And we have to look into the etiology immediately before we start medications because we might miss the cause of it. So we can broadly divide this into remote symptomatic, that is we don't know the cause exactly, or the most common one is symptomatic seizure, that we have a direct cause in front of us. Like for example, a patient coming to you with meningoencephalitis is now going into status epilepticus. So some kind of CNS infection, or commonly some dyselectrolytemia, like severe hyponatremia or severe hypoglycemia or even hypoxia, or there is an intracranial bleed or a stroke. So we have a direct cause in front of us, or it could be traumatic bleed. So all this comes into the category of symptomatic seizures. And the next category is remote symptomatic. So this was previously called as provoked seizures, and this is called unprovoked seizure. Now the terminology is changed. Unprovoked seizure is called remote symptomatic seizure. So here we don't have a direct cause. So we have some remote cause that it could be, for example, there is mesial temporal lobe sclerosis. We have some kind of sclerotic focus or scar tissue in the brain, but we don't exactly know the cause. So that is causing seizure. So something happened long before, some infection happened during the perinatal period, and that is now producing seizures. So that is remote symptomatic seizure. So this is the etiologic classification. So we have to classify this because we have to know the cause. So it helps you in treating it. So these are the major two types, that is symptomatic and remote symptomatic. So that is the etiology classification. We'll also look at some risk factors. The first risk factor is a history of previous status epilepticus. That is, the child has a similar history in the past. That is the main risk factor. And you have to remember that 10 to 20% of children with epilepsy will have one episode of status at least. So, an history of previous seizures or a seizure disorder has to be taken. And status epilepticus presenting as the first time in the case of epilepsy is around 12% of children. Okay, and then other risk factors include focal background EEG changes, focal seizures with secondary generalizations, and occurrence of status epilepticus in the first seizure. All these are risk factors, and even young age, that is 1 year or less than 1 year, is also a risk factor. And obviously, an underlying genetic factor or a genetic syndrome like Dravet syndrome, wherein you have a combination of febrile seizure and as well as afebrile seizure, or any other genetic syndrome which predisposes for status epilepticus, like children with Angelman syndrome are also prone for multiple seizures or febrile seizures plus. So all these genetic syndromes also predispose the child to have an increased incidence of status epilepticus. So we have to take a quick history because that would probably give us the etiology. So that are the risk factors of status. Coming to the etiology, we have discussed this, that is provoked and unprovoked. In provoked, we have a direct cause like CNS insult, hypoxic insult, metabolic cause like severe hypoglycemia, electrolyte imbalance, severe hyponatremia, hypocalcemia, traumatic brain injury, or drugs and intoxications. So this is usually focused on, that is the reason before we give any anti-epileptic drug, we try to take a tox screen. So that is why it's mentioned. And we also have to rule out any traumatic event and also stroke, that is cerebrovascular event. So all these are risk factors or a provoking agent, which categorizes this status into symptomatic, acute symptomatic status. So this is the etiology in broad. So the outcome for normal seizures is usually the mortality is very less, but with status, the mortalities will slightly raise around 2.7 to 5%, and the morbidity is as high as 15%. And with recurrent seizures, the mortality can raise up to 50%. And with refractory status, we'll also read into the definition of refractory seizure, refractory status. With refractory seizures, the mortality is pretty high, almost ranging from 17 to 32%. So this is pretty high. So usual complications include cardiovascular failure, respiratory complications, and metabolic complications. So this is because of both the seizure activity per se and also respiratory and ventilatory support. So usually these patients end up in PICU and long-term ventilation because we'll be starting on multiple anti-epileptics and anesthetics. So they tend to have respiratory and cardiovascular complications as well. So that is the outcome of status. So we have to classify status epilepticus based on 4 parameters. That is, first thing, semiology. We have looked into whether it is focal status, focal with awareness or without awareness, or is it generalized status, or is it an absent status? So that is based on semiology. We also looked into etiology. That is it a provoked seizure and an unprovoked seizure? Provoked seizure is acute symptomatic and unprovoked seizure is remote symptomatic. And we also have to take an EEG simultaneously and correlate it to the EEG parameters as well to taper our treatment. And we also look into the age, because younger the age, we have worse the prognosis. So these are the axis of status epilepticus. We have to categorize the status before we proceed further. So these are the new terms which we have to know. First of all, we have already studied the definition of status. That is, previously it was 30 minutes and now it is 5 minutes only.
Please do not disturb the speaker by putting in these green highlights. Whosoever is doing it, please remove it and behave properly.
So we have newer definitions. That is, we have to know about NOS, fires. We'll discuss this in detail. So as of now, we know that status is 5 minutes for generalized tonic-clonic seizures. That is T1. So we'll look into what are these newer terms. So first thing is NORS, that is new onset refractory status. So new onset is basically we don't have a cause for it. That is, there is no pre-existing neurological disease. So there is no history of seizure in the past, or there is no epilepsy in the past, or there is no current event which has caused this status epilepticus. So there is no structural or metabolic cause as well. So in the first 5 minutes, we would have taken all the samples, that is sugars, electrolytes and all, and we do not find any cause and we do not have any history. So we can put that as NORS, if at all that seizures go uncontrolled and they go into refractory seizures. FIRES is basically febrile infection related epilepsy syndrome. So this is a subcategory of NOS with prior febrile infection in the last 2 weeks, but not within 24 hours, because if it comes in 24 hours, then that would be included in febrile seizures, febrile status epilepticus. And then you have refractory seizures. We'll discuss this in detail. So status epilepticus persisting beyond the point wherein we have given the short-acting benzodiazepine and also a first-line anti-epileptic agent. So beyond that, the seizures are still persisting. That we call as a refractory status. So once you label the child as refractory status epilepticus, you have to it's that you have to shift the patient into an ICU setup, and you can go for a second-line agent in the first-line drugs, or we can directly go into midazolam infusion. So on midazolam infusion or a second-line agent, also if the seizures are not controlled, then we start anesthetics. So seizures persisting at least 24 hours after the onset of anesthesia. So anesthesia, we usually start propofol or pentobarbital. So even after starting anesthetist in the ICU, after 24 hours, still the persisting seizures, then you label that as super refractory seizures. And if this condition persists more than 7 days, so this becomes your prolonged refractory status epilepticus. So this is 24 hours and this is 7 days. And prolonged super refractory, that is need of anesthetics and still the seizures are not controlled, and that is beyond 7 days, that is prolonged SRSC. So we'll discuss this in detail in the few slides. So as soon as a patient comes to you, if the patient is seizing, the first thing we do is we try to stabilize the patient before rushing into and giving all the anti-epileptic drugs. So we stabilize the patient, that is ABC, because there is a risk of aspiration. So you have to look at the airway, breathing and circulation. You have to look at the peripheral signs. They have to check the RBS. You take a sample of CBC to rule out any infection. Serum electrolytes to rule out. All these are basically to rule out acute symptomatic seizure, because we have to rule out the acute inciting agent. We also take tox screen and also AED levels. AED levels are especially important with this previous history of seizure and if the child is already on anti-epileptic drug. So after doing all this, then we give a short-acting benzodiazepine. So this short-acting benzodiazepine is usually midazolam in our setup, or it could be lorazepam, or it could be diazepam. So these two are preferred. We look into the doses. And after aborting the seizure with a short-acting benzodiazepine, so preferably we have to give it IV or IM. If there is no setup, or if the patient is not in the hospital setup, we can also go for intranasal midazolam. That is given at a higher dose. So intranasal midazolam is also easily available in India now. And after aborting the seizure with a short-acting benzodiazepine, you start the patient on first-line anti-epileptic agent. So there is no evidence of which drug is superior over other. All three are equally effective. So you can start fosphenytoin or valproate or levetiracetam. Fosphenytoin is not available in India, so we replace it with phenytoin, though it has some disadvantages. So you start either of this as the first line anti-epileptic agent. So this is second therapy because we are followed by benzodiazepine. So we can, even after this stage, the seizures are still persisting, then you have to either use another agent of this first line agents, or we can directly go into midazolam infusion. So first 5 minutes is basically stabilizing ABC and collect the samples. Initial therapy phase, you give a short-acting benzodiazepine. Second therapy, you start giving a second agent. And after this, you go for infusions and anesthetic drugs. So these are the drugs. We'll come back to this. So this is the treatment protocol. As I said, this is the first minute we have to stabilize the child. And if at all there's hypoglycemia, you have to treat hypoglycemia. And if the seizures are still persisting, then you have to go for intramuscular midazolam, lorazepam, or diazepam. So midazolam is usually given at a dose of 0.1 to 0.2 mg per kg per dose. So you can repeat this dose. The same dose is for lorazepam. And the maximum dose for midazolam is 4 mg per single shot. So you can use in either of these short-acting benzodiazepine to abort the seizure. And as soon as the seizure is aborted, for example, the seizure is not aborted, you can repeat this dose after 2 to 3 minutes by once. The same midazolam can be repeated twice after 2 to 3 minutes of gap, and still the seizures are not aborted. Either ways, you start on first line long-acting anti-epileptic. So this choice is usually fosphenytoin, valproin, or levetiracetam. So the doses for this is phenytoin and fosphenytoin, both are given at a dose of 20 mg per kg. Valproate is at 40 mg per kg, and levetiracetam is at a dose of 40 to 60 mg per kg. So the maximum dose of phenytoin and fosphenytoin is 1500. Valproate it's 3000. For levera it's 4500. So you know that phenytoin cannot be infused fastly because we know that we have a potential complication of cardiac arrest being developing. So we have to not exceed the rate of phenytoin more than 1.5 mg per kg per minute. So take for the dose of 20 minutes, it should be infused over at least 20 minutes. So that is the care we have to take for phenytoin and fosphenytoin. But fosphenytoin has a better profile and less side effects, irritation and all. But we do not have fosphenytoin, so we use phenytoin. So that must be kept in mind that we infuse that slowly, at least over 20 minutes. Or you can go for valproin, or we can go for levera. All three are equally effective. There's nothing, no agent which is superior over other. And after this, if the seizures are still persisting, so the next option is you can go for a second line agent. The second line agent is the other drug used from this. For example, if you have used phenytoin, you can now use valproin. If you have used valproin, you can use phenytoin or levera, like that. So you can use a second agent beyond the point if the seizures are not controlled. So some use a second line agent as the other one of these drugs, or some usually prefer to go for midazolam infusion. So either ways, it's fine. There's nothing better, nothing proven to be superior over others. So once you have given valproin, you can go for midazolam infusion directly, or you can load with another anti-epileptic agent, that is like fosphenytoin or levera. So as soon as you start the patient on midazolam infusion or a second line agent, that becomes your refractory status epilepticus. So refractory status epilepticus, you have to treat with infusions. That is, midazolam infusion is usually started at a dose of 0.5 to 0.4. We can go till 0.45 to even 2 milligram per kg per hour. So this is the dose of midazolam infusion, and we can even go up to 5 also. So ideally, midazolam is known to cause respiratory depression. So preferably this should be done in a PICU setup. So that is the dose of midazolam. And on midazolam and second line agent, if the seizures are not still controlled, then you might have to go and start your anesthetic agents. So anesthetic agents of choice is usually propofol or thiopentone or pentobarbital. So thiopentone usually has severe side effects like hypotension and respiratory distress. So you can usually use propofol. So propofol is usually used at a dose of, you have to load the child with 2 mg per kg dose, and you have to give a maintenance dose of 5 to 10 mg per kg per hour. So even after starting anesthetics and it has passed 24 hours and the seizures are still persisting, and then you label that as super refractory seizures. And these super refractory seizures, if they prolong with 7 days, that is called prolonged super refractory seizures. So beyond propofol, we can also go for thiopentone, and we can also go for pentobarbital coma. So the pentobarbital dose is usually given at dose of 5 to 15 mg bolus per kg bolus, and you have to start a maintenance dose of around 0.5 to 5 mg per kg per hour. So this is the dose of pentobarbital. So this is how you proceed. You start with a short-acting benzodiazepine, then you go start load with first-line anti-epileptic agent, that is valproin, phenytoin, or levera. And then second line, you can use one of these again, and then go for midazolam infusion or Then you go for anesthetic agents like propofol or thiopentol, and then manage accordingly. So ideally, this should all be done in PICU, and if needed, ventilator support should be given. So that is all.
So basically, Jayanth, when we are managing status epilepticus, what are the side effects for these drugs which you have mentioned? Please elaborate.
So first thing is basically we'll see that with each drug. So we don't use diazepam often. We know that midazolam is most commonly used in a setup. So we make sure that midazolam should not be given above the dose of 4 mg per dose. So before if it is under the dose of 4 mg, usually the complication